Good morning, good afternoon, and good evening. Welcome to this global launch of the Lancet Global Health Commission on financing primary healthcare, putting people at the centre. I'm Zoe Mullen, and I'm the Editor-in-Chief of the Lancet Global Health. So today we're going to take you through a series of things. I'll just very briefly introduce myself. Then we'll have a welcome from Professor Anne Mills, who's the Deputy Director and Provost of the London School of Hygiene and Tropical Medicine, where the lead commissioners were based. We'll then go into an overview of the Commission, where some of the commissioners will be speaking very engagingly about the findings. There's no dry PowerPoint slides for you today. I hope you'll enjoy their presentation. And then we're going to have a panel discussion from some external commentators on the Commission, reflecting on their take on the Commission's findings and what that means for them going forward. And then Cara will finish. So, as I said, my name is Zoe Mullen. I'm the Editor-in-Chief and set this Commission going. Before I briefly introduce how that happened, I'll just run through a few housekeeping things for you. So you'll see that we have a dashboard here. It's a little bit different from Zoom. You should see probably in the bottom right-hand corner of your screen a Q&A. So this is a question and answer box where you can add questions to the commissioners and also the panelists, and we will have a section at the end in which we will answer them, or we may actually answer them as we go through in the text. You can also see there should be a box entitled related content, and in this box you will be able to see all the items that are actually relating to the Commission, so you'll be able to link to the Commission itself so you can read it and enjoy all the associated things we've presented with it. And you can actually move the boxes around on the screen. If you click on the corner of any of the boxes, you can make the slide box smaller. You can make the picture, the presenter's box bigger, however you would like to have a look at it. When we have finished, there will be an on-demand version. So if you don't have time to watch all of it today, or you'd like to email it to a friend, you will get emailed a link for that. Okay, so how did we arrive at this point? Well, in 2018, the Lancet Global Health published its first commission entitled High Quality Health Systems for the Sustainable Development Goal Era, Time for a Revolution. And that commission argued that in the drive towards universal health coverage, there was a moral imperative to consider a basic level of quality, showing that more people globally die from poor quality care than from lack of access to it. And one of the four main recommendations of that commission was that countries should redesign service delivery to maximise health outcomes, not geographical access. And one of the key elements of service redesign was a greater focus on primary healthcare, or PHC. PHC is ideally suited to managing the rising tide of non-communicable diseases, and as the Astana Declaration reaffirmed, is the most inclusive, effective and efficient approach to enhancing people's physical and mental health. So if we can agree that strengthened primary care is our ticket to UHC, how are we going to get there? And more pertinently, perhaps, how are we going to pay for it? This is the challenge tackled by our latest commission, which we're delighted to present to you today. 24 commissioners from 15 countries set out to explore the current landscape of financing for PHC, the best ways to mobilise funds, the best ways to allocate those funds, and the best way to incentivise healthcare providers. In all of these functions, the Commission uses a similar frame of reference to that of the High Quality Health Systems Commission, i.e. people, both patients and providers, and equity. I won't give any more away, but I hope what we're about to share with you is informative, thought-provoking, and perhaps challenging. And we do encourage you to share your views in the Q&A box at the end. So Without further ado, I will hand over to Cara Hansen, who's Professor of Health System Economics and Dean of the Faculty of Public Health and Policy at the London School, and who is the lead commissioner on this commission. So thank you very much. Enjoy the presentations, and I look forward to engaging with the question and answers at the end.
Thank you so much, Zoe. And I'd like to add my welcome to this launch event, which is really the culmination of 2 years of hard work by the commissioners and by my research team here at the London School of Hygiene and Tropical Medicine. I've had the enormous privilege of chairing this outstanding group of commissioners who are responsible for this report. They're drawn from the worlds of research and policy and practice, and they brought a wealth of experience and expertise on the subject of health financing and health systems to our discussions. We are all very much looking forward to sharing the findings and recommendations of this report with the audience today. Before we do that, I'd like to turn to Professor Anne Mills, who's the Deputy Director and Provost of the London School of Hygiene and Tropical Medicine, who's going to add her welcome to it.
Welcome. My name is Anne Mills. I'm the Deputy Director and Provost of the London School of Hygiene and Tropical Medicine. And I'm very pleased on behalf of the school to welcome you to this launch of the Lancet Global Health Commission on financing primary healthcare. In previous years, the launch of a Lancet Commission would have enabled me to welcome you to our London buildings. But this webinar format means I can welcome a far larger audience than would fit in our John Snow lecture theatre, and an audience from all over the world. We've been delighted to be the hosts of this important commission, which has been chaired by Professor Cara Hansen, Dean of our Faculty of Public Health and Policy. In fact, I'm especially delighted with this launch, since I myself am a health economist. I've worked on primary healthcare and health system financing in the past, and it's a topic dear to my heart. There have been many authoritative accounts and studies of the importance of primary healthcare. We know that access to basic healthcare of good quality is highly valued by everyone. We also know that historically, the development of primary care has made a critical contribution to improved health across the world. Most recently, COVID-19 has shot a spotlight on the role that a strong primary care system can play in helping respond to huge public health crises. But we also know that primary healthcare is commonly under-resourced and undervalued. Its workers often lack status relative to hospital-based professionals. Primary care facilities lack drugs and well-trained and remunerated staff. People often have to pay in some way for care, even when it's meant to be free, and can often not afford to pay. Money is not the solution to everything. But without an adequate system of financing primary healthcare, it's difficult to make progress on any other dimension of the primary care system. As the report puts it, money is the fuel of health systems. New evidence gathered by the Commission demonstrates just how little fuel is provided to primary healthcare, especially from public sources. An average government spending of $3 per capita in low-income countries falls far short of any sensible benchmark of how much might be needed to finance a basic package of services. As a researcher, I would be the last to say that we have all the technical knowledge to hand to address the challenge of financing high-quality primary healthcare. But we do know a lot about technical approaches and how they work in. Welcome. My name is Anne Mills. I'm the Deputy Director and Provost of the London School of Hygiene and Tropical Medicine. And I'm very pleased on behalf of the school to welcome you to this launch of the Lancet Global Health Commission on financing primary healthcare. In previous years, the launch of a Lancet Commission would have enabled me to welcome you to our London buildings. But this webinar format means I can welcome a far larger audience than would fit in our John Snow lecture theatre, and an audience from all over the world. We've been delighted to be the hosts of this important commission, which has been chaired by Professor Cara Hansen, Dean of our Faculty of Public Health and Policy. In fact, I'm especially delighted with this launch, since I myself am a health economist. I've worked on primary healthcare and health system financing in the past, and it's a topic dear to my heart. There have been many authoritative accounts and studies of the importance of primary healthcare. We know that access to basic healthcare of good quality is highly valued by everyone. We also know that historically, the development of primary care has made a critical contribution to improved health across the world. Most recently, COVID-19 has shot a spotlight on the role that a strong primary care system can play in helping respond to huge public health crises. But we also know that primary healthcare is commonly under-resourced and undervalued. Its workers often lack status relative to hospital-based professionals. Primary care facilities lack drugs and well-trained and remunerated staff. People often have to pay in some way for care, even when it's meant to be free, and can often not afford to pay. Money is not the solution to everything, but without an adequate system of financing primary healthcare, it's difficult to make progress on any other dimension of the primary care system. As the report puts it, money is the fuel of health systems. New evidence gathered by the Commission demonstrates just how little fuel is provided to primary healthcare, especially from public sources. An average government spending of $3 per capita in low-income countries falls far short of any sensible benchmark of how much might be needed to finance a basic package of services. As a researcher, I would be the last to say that we have all the technical knowledge to hand to address the challenge of financing high-quality primary healthcare. But we do know a lot about technical approaches and how they work in different settings, and we've known enough for many years. The bottleneck is less technical knowledge, as it's adaptation to specific political, sociocultural, and economic circumstances. This, to me, is the most important message of the Commission, that politically informed technical strategies are needed. And the report is indeed rich in examples of such strategies that countries may use to increase primary healthcare financing, encompasses strategies like for revenue mobilisation, pooling, resource allocation, and provider payment, all critical elements of a well-functioning system of financing primary healthcare. I want to end by thanking the Commissioners, the Secretariat, and all the researchers and research groups in countries listed in the extremely impressive acknowledgements at the end of the report. I know that this Commission was conceptualised in the pre-COVID era and had to work out a way of working that ensured that everyone's voices could be heard and that made best use of people's expertise while working remotely. It's a huge achievement to produce such a valuable report in such difficult circumstances. So thank you to everyone. I do hope you enjoy this launch event and all the discussions it will undoubtedly provoke.
Super, thanks very much, Anne. Apologies for the glitch there. And can I just remind my fellow presenters not to move your mouse around too much because that risks interrupting some of the flow of slides. So before we turn into the substance of the launch, I'd like to start with a very brief poll and quiz to encourage those of you who are joining to check in with your own knowledge and your understanding of PHC financing. So the first question is, how much do low-income country governments spend on PHC? So this is a multiple choice question. I'm going to run through all three questions and we'll look back at the answers together. So I'll give you a few seconds to click your answers on, and then Mike will move the questions through. Okay, Mike, do you want to move on to the next question? Right, so the next question gets to the issue of the role of user fees for primary health care. So does your country have formal user fees to access primary health care in the public sector? It's a straight yes or no question. And here we're not talking about informal fees. We're really interested in whether there are formal fees that are officially charged. Thanks, Mike. And then the last question is, what's the main way that public PHC providers are paid in your country? So are they paid through capitation, a fixed amount per person? Are they paid through an input-based budget? Are they paid through fee-for-service or some form of case-based payment? Or are they paid for performance through a pay-for-performance type system? So if you can answer that question, then we can look and see what everyone has answered to the three. Okay, Mike, can we go to the results then? Right, so those of you who listened very carefully to Anne's introduction will know that low-income country governments spend less than $4 per capita on PHC. And that, if you think about the sorts of benchmarks that have been set in the past for kind of a package of basic healthcare services of $60 or $70 US per capita, this is just really tiny in terms of the commitments that are needed. So most people knew the right answer to that one. And over to the next result, please, Mike. Does your country have formal user fees? So about half-half. So about half of the respondents here in this room have answered that user fees are charged to access PHC. And as you'll see in the report, user fees can be a considerable barrier to accessing primary health care. And there's lots of good reasons, both in terms of access and in terms of financial protection for removing user fees as much as possible. And then the last question again, Mike. So how are PHC providers paid? So a variety of an interesting distribution of responses here. Interestingly, just under half of respondents have pointed to capitation or some fixed amount per person being paid for. But input-based budgets is actually I think in many low-income countries in PHC settings, input-based budgets are a really common way of paying providers for PHC. But there's still a lot of fee-for-service and indeed some of these per capita-based payments as well. You'll see as you flick through the report and as we present the report to you that, that the way that providers paid has a really powerful effect on both on money reaching PHC, but also the incentives that it sets for PHC. And we have some very specific recommendations on this. So now I'm going to turn to the substance of the launch, and we're going to start with the presentation of the main findings of the report. And as Zoe said, after that, we'll move on to a live panel discussion. So perhaps we could just move now on to the main report findings. Thanks, Mike.
The reason why I got involved in the Commission's work is because I know that access to primary health care is second to nothing in guaranteeing health care for children and women in low and middle income countries.
So primary health care really is the foundation for achieving the Sustainable Development Goals. It's the level of the health system where priority, low-cost interventions are delivered, and it's going to be the location where non-communicable diseases, which are such an important part of the changing burden of disease, will be managed. PHC is even more important now that we are managing COVID. It's shown us the really close links between health and the economy. The countries with strong PHC systems have managed the COVID pandemic much more effectively. But also, as we move forward, PHC will be the foundation of responding to future pandemics.
My experience has shown that PHC is the most important component of healthcare. And if you don't get the foundation right, the rest of the system is not going to shape out well.
Primary health care is the foundation of all well-functioning health systems. And the financing of primary health care is vitally important for shaping those systems.
Financing PHC is critically important because it will reach the underserved population, reduce the disparities among the rich and the poor, and help countries to meet UHC targets.
So health financing arrangements determine how much money is available. They determine how funds are pooled to help manage risks across different population groups. They determine how the money flows to frontline healthcare providers, and it shapes the incentives they face. Primary healthcare at the moment is underfunded, it's underused, it suffers from problems of low quality, bypassing, and it's really failing to meet its promise.
The reason why we're talking about financing PHC is because in a low-middle income context, the majority of the rural population will access health services via the primary healthcare. PHC creates a platform, a pathway to achieving universal health coverage.
The purpose of the Commission was to develop a set of recommendations that would help countries to change their financing systems in support of PHC. The vision of PHC that was guiding this was one that is integrated and comprehensive and equitable and high quality, and that both the system and the financing arrangements underpinning it would put people at the center.
The work of the Commission can point policymakers to identifying what the problem is and then taking baby steps in trying to change organization and financing together.
Our commission was made up of 22 commissioners. Over the course of 2 years, we reviewed existing evidence, we conducted a new survey of provider payment mechanisms, we commissioned a set of country case studies, and we held some round tables. And together, the commissioners reviewed this evidence and were able to put together a picture of how financing for PHC can be strengthened. This picture looked at each of the main financing functions. We looked at how to mobilize more money for PHC, how to allocate it to PHC and make sure that it reaches frontline providers. We looked at how PHC providers are paid, and we also unpacked the political, social, and economic factors that enable transformations in PHC financing.
Although primary healthcare is perhaps the most important part of the healthcare system, there's still a lot of uncertainty around the level of primary care spending across country. So we did quite a lot of work as part of this study to try and improve that. Despite the absence of data, we were able to find some really interesting patterns in primary care spending globally. In low-income countries, the average spending was only $3 by government per year, which is very low. And the predominant form of financing of primary healthcare in low and lower middle income countries is out-of-pocket expenditure and to some extent donor funding, which means that for many really poor households that they're not able to fund primary healthcare. And as what happens in many countries around the world, you have to sell a cow or a sheep before you go and collect your antihypertensive medicines or get other basic primary healthcare. And it's only as one starts getting into the high-income groups that you really see substantial government revenue raising and pooling to be able to provide primary health care to populations on a substantive level and moving away from this predominant reliance on out-of-pocket payments sources for primary health care.
Insufficient government funding means that households have to pay for primary health care from out-of-pocket spending. Out-of-pocket spending includes user fees, and user fees can serve as a barrier to accessing healthcare, which is particularly a challenge for the poorest households. For those who choose to pay, that can lead to financial hardship.
Financing for primary health care is currently very fragmented between out-of-pocket sources, donor sources, and government spending. And that potentially leads to inefficiencies, but also not funding at an adequate level for the most important primary healthcare services.
There is surprisingly very little information on how countries organize their primary healthcare system and how it's financed. Therefore, we decided to do our own survey and send this survey to 107 countries. And we managed to get 75 responses. And from this survey, we learned so much about how PHC providers are organized in the country, how community health workers supporting the public sector are paid, and how PHC providers in each sector are paid by different payers.
The survey found some really interesting results on paying for primary care providers. In developed countries, the predominant mechanism of paying such providers is through population-based payment mechanisms, such as capitation. What we found in the low-income countries is the predominant way of paying primary care providers is through input-based payment methods. That means paying separately for staff, or medicines, and all the different components. So the survey looked at levels of autonomy of primary care providers, and it found clinics, for example, couldn't decide how they would pay their staff, what service mix to provide, to be able to reward performance. In general, there was a very low level of autonomy.
One of the key observations emerging from the Commission report is that not enough money is spent on healthcare. Not enough investments are going into the health sector. And in order to keep up the promise of the Sustainable Development Goals, we need to increase this investment. We need to be spending more on health.
Low and middle income countries really struggle to raise resources for health for a number of reasons. There's limited tax revenue, for example, and that can be caused by macroeconomic conditions that are not very favorable. And we know post-COVID that there's going to be austerity measures coming in. But there's also real weaknesses in the way that the tax system is organized and is structured. On top of taxes, there's also an issue with social health insurance, which is difficult to organize in low and middle income countries because the labor market is mainly informal rather than formal. So considering all these difficulties in raising resources, there's a lot actually that countries can do to try and ensure that there's enough resources for health. The first thing would obviously be to grow economically. Now, failing that, especially considering the situation with COVID, taxation is the key word. Finding a way to increase the tax base, to increase the types of taxes that are being levied. And we know that this is very difficult to do, but countries have done it, so it is possible. A lot of countries have also attempted to implement taxes that are politically more acceptable. And at the moment, we're calling them health taxes, and those are taxes that are focused on products that are harmful to health, for example, tobacco or alcohol. So whatever happens in terms of raising more resources for health, it's fundamental to pool resources, to facilitate cross-subsidization between rich and poor, healthy and sick. Ministries of finance very often say to ministries of health that they need to spend their money better. Spending money better is often equated with spending less. Actually, spending money better may be spending more, or you may be spending the same. It's really about the efficiency of spending to get better health. The evidence behind the ability of efficiency reforms to create fiscal space is not so strong. What we see also is that it takes a long time for those reforms to be implemented. And even when they are implemented, they may not translate in additional resources for health.
Prioritizing investment of primary health care requires government commitment. It requires aligning investments of partners towards government priorities in these areas. It requires a concerted action by all partners and government to really mobilize the resources towards primary health care if we want to achieve universal health coverage.
There's two big problems with resource allocation for PHC. One is that insufficient money is allocated from the government budget to PHC. And the second is that those resources then don't find their way through to frontline providers.
So on the one hand, at the budget formulation stage, there's real issues with aligning the policy objectives of ministries of health with the PFM processes. There's also an issue with the credibility of health budgets. There's a lack of data, so what actually gets to ministries of finance tends to not really be believed. In practice, what happens is that ministries of health budgets tend to just be the same as last year plus a little bit.
Allocating resources to primary health care is a political issue as well as a technical issue. The primary health care platforms generally get less political support than higher levels of the health system. Primary health care tends to benefit people who have little political voice, women and children. Primary health care, if it's working well, actually reduces need and keeps people healthy, which makes it even less visible in the health system. And finally, in government budgets, there's often no specific line for primary health care, so it's invisible in the budget, which makes it harder to protect those resources.
Whilst it may seem really complicated to allocate resources to primary health care, actually there are things that country can do. And there are 3 levers that we talk about in the report.
The first set of tools are around budget formulation. So one approach is to actually create a budget head for primary health care that makes it visible in the budget and can operate alongside the more traditional input-based budgeting approaches. There's also a set of tools that can be used to identify and ring-fence resources for PHC. Things like conditional grants or budget rules that say that you have to allocate a certain share of the budget to PHC. We've seen in India, for example, that the use of budget matching processes through the National Health Mission seems to have been effective at getting states to spend more on PHC. A second set of tools are about budget execution. So the Commission comes out with 2 recommendations here. One is around the greater use of a resource allocation formula that can be used to allocate equal amounts of money across different geographical areas that can help to improve equity. But there's also a set of tools around service purchasing that can help to protect resources for PHC. These include setting a clear benefit package and then using the provider payment system to shift resources towards PHC. Service delivery arrangements are another way of influencing allocations to PHC. This can be through setting norms and standards that then have to shape resource allocations. It can also be around reconfiguring service delivery. In some countries, creating a new cadre of community-based health workers has been a way of pulling resources to PHC.
It matters how you pay healthcare providers because the way you pay them generates certain incentives, and those incentives can influence how health workers behave, their motivation, and ultimately that can carry through into the quality of care that they deliver.
Our vision under this commission is that countries need to move toward a blended provider payment mechanism. We are proposing capitation to be the core of this blending. Capitation is the only provider payment system that is about population, and it takes into account the issues of equity at the very point of design. So you pay the providers based on the number of people that are using services. But also, with the capitation, there is more flexibility because you pay the money in advance, and then you allow the primary healthcare providers to prioritize provision of services based on the needs of the population. So to a large extent, you create incentive for the providers to be innovative and creative to improve the quality of services.
So capitation does have some drawbacks. Most notably, it perhaps incentivizes excess referrals to hospitals, and secondly, it can also promote under-provision of care. So this is why we suggest that there should be a blended payment method.
The starting point is really very simple capitation, so that you leverage that playing field across all the service providers. And once you have done that, you would want to do some of the risk adjustments so that you can improve the design of your provider payment mechanism.
So even a well-designed payment system cannot work well unless you have basic supporting functions in place. And these need to evolve as the payment system also becomes more sophisticated. So they include continually strengthening information systems, increasing or strengthening the capacity of purchasers, supporting the public financial management systems, and giving more autonomy to healthcare providers. And one thing we mustn't forget, it's very important to manage the politics of reform. So, for example, anticipating how different stakeholders might react, anticipating who are going to be the winners and losers within any reform.
The Commission argues that political economy is an important factor that we have to consider when transforming primary healthcare financing. Usually, primary healthcare financing reform is considered as a technical solution, technical fix, but what we have to do is to consider the economic and the political factors which underpin this reform. So what is political economy? We understand this as an exploration of the politics, the economics and the power dynamics between different groups in our societies and how these relate to distribution of resources. Our political economy analysis framework has 3 domains which are interrelated. So this is the political domain, the social, and the economic. The political domain is the groups, the organizations, the individuals, the alliances, the contestation of the process. The economic domain is the structure of the economy, the sectors, the share of the private sector, productivity, and the social domain. These are the inequalities, the social claims, the social struggles and grievances, and the social norms. They are interrelated, they are changing over time, they need to be constantly monitored. And doing that will allow us to design politically informed technical solutions. So how do we get all these actors to go together? Is it even possible? The first step is to think about forming alliances. And it is possible to do. We see examples such as from Estonia, where even from the 80s, there was an effort to actually get the actors together, to change the idea of what's a primary health care. Another way to bring the different actors together is to think of the concept of the whole-of-government approach, which would enable the actors to work together and to work around coherent policies. But we shouldn't also forget the role of the policy entrepreneurs, the technocratic elites who are able to bring both the technical expertise and the political clout, and they will contribute to establishing this vision of primary health care and making it happen.
Social factors have shaped the way in which PHC has been financed in many different countries. And we've seen this, for example, if we look at the level of inequality in a country, we've seen that social grievances have had an impact on whether financing to PHC has happened or not. Economic factors have an enormous impact on whether or not PHC will be financed. And those factors can include, for example, the structure of the economy. We talk of the example of Tanzania, where less than 300 organizations provides nearly 75% of the revenue of the state. Obviously, those organizations are going to have an enormous impact on what gets or doesn't get funded.
So how do we deal with this dynamism and constant change? The first thing is to have a vision, something that guides the policy process, the health financing reform, over decades sometimes. This long-term vision would allow us to think about sequencing, to take advantage of opportunities or generate demand for technical solutions. Another important thing to do is building capacity for political economy analysis. We know it's not always there, so we need to look outside the health system. We need to think in terms of local governments, local structures, and how do we harness this when designing technical solutions. We also have to learn that political economy is not just finding out what the constraints are, what is there, but thinking about responding, the windows of opportunities, what can we do, what can we anticipate, and be responsive to the rapidly changing political and socioeconomic climate.
So the Commission concludes that we need to spend more and spend better on PHC, and that people should be at the center of these arrangements. So our report makes 4 recommendations. The first is about the attributes of people-centered health financing. Public resources should be at the core of people-centered finances for health. In most countries, this will mean increasing allocations from tax revenue, with a commitment to continued external assistance for low-income countries, so they have enough resources for essential PHC services. Pooling arrangements should cover PHC. This will help to reduce out-of-pocket payments and enable cross-subsidy. So resources should be allocated equitably and protected to reach frontline PHC providers and patients. This means using strategic resource allocation tools, budget formulation, budget execution, and service delivery arrangements to enable this. Provider payment should work towards a blended payment system with capitation at its core. This will allow resources to be based on health needs and to create an incentive environment that promotes people-centered PHC. Our second recommendation is that countries should take a whole-of-government approach to spending more and spending better. Third, technical strategies for PHC financing need to be underpinned by a clear understanding of the social, economic, and political conditions that enable progress. Fourth, the report makes some very specific recommendations about the way PHC expenditure data are collected, classified, and reported. Most important, each country should establish its own definition of PHC expenditure that's compatible with how its services are organized and use this definition to track progress towards commitments over time. Together, these recommendations set out a vision for financing PHC that serves a greater ambition, which is a system of primary health care that is equitable, comprehensive, integrated, high quality, that serves the needs of communities and is compatible with universal health coverage.
The recommendations of the Commission can be a starting point for persuading policymakers to try out some of the recommendations that are contained in the Commission.
I would take the recommendations forward in Sierra Leone by going back to the Health Financing Unit at the Ministry of Health. And the beauty of this is that it brings recommendations from other contexts. This would help with advocacy in getting more resources mobilized for financing primary healthcare in Sierra Leone.
So I will use the recommendations of the Commission to really share with government to take the recommendations forward, to generate evidence and build systems and capacities in the country.
Primary healthcare financing is a simple, straightforward, and goal-oriented framework on which such social contracts can be established. There are leaders who are serious-minded in low and middle-income countries, and I believe that this brilliant work that has been done by the Commission provides a template that such leaders can ride on, as they take steps to move their countries and their citizens towards achieving health security.
So I hope you found that presentation of the Commission's findings and recommendations stimulating and thought-provoking. And I would encourage you to keep asking your questions in the Q&A and in the chat, and use the chat function to engage each other in this discussion. We're now going to move to the next part of our event, which is a panel discussion facilitated by Cheryl Cashin. Cheryl is the Managing Director of Results for Development, and she's a health economist specializing in the design and implementation and evaluation of health financing policy in low and middle income countries, with a particular focus on purchasing and provider payment. She'll be known to many of you for her work through a number of platforms that have looked to find new ways of contributing technical support and guidance to countries that are addressing complex health problems. Cheryl is one of our 22 commissioners, and she's made some really, really important contributions to our thinking, to our analysis, and our writing. I'm going to hand the chair over to her now and allow her to introduce her panel. Cheryl, over to you.
Thank you so much, Cara, and thank you for the kind words. I'm delighted to be here today. We have an excellent panel of really distinguished experts who have a wide range of really deep experience in primary healthcare financing. We have decision makers from ministries, representatives from academia, provider, and civil societies. So we're going to get multiple perspectives on the findings and recommendations of this report and bring them to life. So we'll start, I think, this panel with just a little bit of reflection from each of our panelists on the findings and recommendations and how they resonate, given the issues of primary healthcare financing in their countries. And then we'll open it up to what I hope will be a very lively Q&A and discussion section. So please continue to put your thoughts, reflections, and questions in the chat, and we'll be able to direct those to the panelists. So I'm very delighted now to welcome our panelists. We first have Ms. Indrani Kaushal, who is an economic advisor to the Department of Health and Family Welfare of the Government of India. We have Dr. Tamar Gabunia, who is the first Deputy Minister for the Ministry for Internally Displaced Persons from the Occupied Territories, Labor, Health, and Social Affairs of Georgia. We have Professor Shabir Musa, who joins us today with multiple affiliations: the Gauteng Department of Health in South Africa, Witwatersrand University, the World Organization of Family Doctors, or WONCA, and the African Forum for Primary Healthcare. And finally, last but not least, we have Dr. Aminu Magashi Garba. He is the founder and coordinator of the Africa Health Budget Network. So thank you all for joining us. A warm welcome to all of our panelists. And I'm going to start by asking each of you to please provide your reflections on any of the findings or recommendations of the report that you find most relevant for the issues facing your country, and how you might take those recommendations forward. And just ask to reflect for about 5 minutes for each of you. And I would like to start with Ms. Kaushal to please share your reflections on the relevance of the findings to your situation in India.
Good evening, Kara. This is Indrani. And since we are on the topic of financing primary healthcare, as we all know, the benefit to cost ratio for any key healthcare intervention is 10:1. So that ratio for primary healthcare would be even more, is that what we feel the Commission has recommended. The Commission has, identified some key principles which focus on universalism and the public sector nature of financing primary healthcare. The emphasis on ensuring public primary healthcare strengthening through adequate financing as a key pathway to universal healthcare is also critical, considering that the more and more investments we do in primary healthcare that has the ability to address a preponderance of disease conditions, besides emphasizing preventive and promotive healthcare. The other principle which I found resonates for the Indian context is the strengthening of the public finance management system tool. In India, the PFMS management reforms have really gained traction over the years, and we have been able to ensure that the resources find their way to the beneficiaries whom they are meant for. On the fifth principle, which addresses the issue of resource allocation to primary health centers based on people's health needs, on the backdrop of COVID, we have understood that ensuring essential public health functions need to be integrated with delivery of services and addressing preventive and promotive care. In fact, the government of India has launched, on the backdrop of COVID, a new scheme, which is the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, which has an allocation of around $8.5 billion, which is rupees 64,180 crores, which is specifically, also addressing this primary health care, and other than that, ensuring that, it will be able to fight the new and emerging diseases. Ensuring seamless, high-quality delivery and ensuring continuum of care, especially considering the high burden of chronic diseases, requires effective and monitoring and measurement systems to enable performance-based systems. Our flagship scheme, the National Health Mission, has in fact progressed from the input-based financing. Now we are looking at new models like performance-based incentives, where not only individual incentives are trying to be built into schemes, but also team-based incentives. So what the Commission, my colleague Commissioner mentioned, that individuals need to be motivated to deliver high-quality patient care. All these principles do find resonance in India's primary healthcare reform initiatives. Our PHC reform started some time back, which was 17 years ago, under the flagship National Health Mission, which in fact emphasized publicly funded PHC systems and linkages to the district strengthening. We believe that if the primary healthcare is strong, then there'll be lesser referrals to the district and the subcenter and the secondary systems. And also as a hub for supporting supervision and capacity building. We also launched the Ayushman Bharat Health and Wellness Centers. We have an ambitious target of 1.5 lakh Ayushman Bharat Health HWCs, we call them, to be set up. And we are well on track to achieve that target. As on date, as of yesterday, already 1.17 lakh have been operationalized. And these are at rural, points which address the continuum of care at the point where it is needed. Under the National Health Mission, we have taken several financing reforms. In fact, we would like to say that the matching grants, which are in your film also, we ensure the states to put in as much, the NHM scheme runs on a 60-40 ratio and 90-10 based on hilly and northeastern states. So we do emphasize that the states also put in their share apart from the union. We also have certain conditionalities to states. We earmark 20% performance-based financial incentives to states. We have worked very hard on simplification of our budgets and encourage flexi pools. So the National Health Commission is in fact recognized for its flexibility, which gives the states. Some states might want to strengthen their elderly care program, whereas some states might want to, work more on ambulance strengthening. So that really has made the difference. We have also removed certain restrictions on fragmentation of a lot of activities. Our FMR reports, the financial management reports, have been made very simplified, and we have made common resource pools. So if we want to do some intervention in reproductive and child care, I can also dip into the health system strengthening pool if I'm running short of resources in the RCH pool. Addressing last mile challenges and persistent inequities, which are key to India's finance reforms at the national level, are also enabled by ensuring that states which are resource poor and have weak health systems are provided with additional funding in conjunction with our differential strategies. So we broadly agree with the Commission's recommendations, and apart from all the union and union funding towards these flagship schemes, we also have a 15th Finance Commission, which has enabled extra grants of rupees 70,000 crores over a 5-year period. This will definitely bring a lot of change at the primary healthcare system. I definitely thank the Commission for this opportunity to showcase the initiatives which India has launched as part of our government's work. Thank you, Cheryl.
Thank you so much, Ms. Kaushal, and I really appreciate a lot of the points you made, of course, but the focus on the importance of public financial management really came through to me, and I'm so glad that you highlighted that. We often forget that part of health financing, and your point about needing to make the system flexible to adapt to emerging challenges, as we found with COVID. So thank you very much for highlighting that. And the movement also then from more input-based approaches to more performance-based approaches is part of that flexibility. Thank you so much for those insights. I'm going to switch to a different context now and invite Dr. Gabunia to share reflections from her perspective in the ministry in Georgia.
Thank you. This is actually a great opportunity for me to reflect on the report, which presents very important work and describe how PhD development happens in Georgia. Being a family medicine practitioner myself, actually I understand how important it is to strengthen PhD system, and these days, after we went through the COVID pandemic, it became even more important and really obvious that without having a well-functional primary health care, a country can hardly achieve its SDG goals, neither it's possible to manage important public health emergencies like COVID pandemic. So COVID pandemic created significant challenges for the health system in Georgia, but it also highlighted the importance of comprehensive and people-centered PHC services. Prior to the pandemic, many Georgian citizens did not utilize PHC services and were not aware of their assigned PHC provider, but a digital portal launched in November 2020 made it possible for citizens to connect with their family medicine practitioners and clinics where they were registered in the event they demonstrated COVID-19 symptoms. Individuals not registered with any PHC provider were assigned to a family doctor in accordance with their place of residence. In response to the pandemic, mixed modalities of service delivery have been introduced, combining face-to-face in-facility consultations with face-to-face at home and remote, online, and telephone consultations. Moving existing services online allowed for delivery of essential services closer to the people, thereby increasing access to and reducing disruption in services, not only due to the pandemic, but by physical access barriers. More than 1 million individuals received COVID home care provided by a qualified family doctor. Family medicine practitioners were actively involved in COVID vaccination and testing programs as well. At the same time, COVID pandemic strengthened political commitment to advancing comprehensive PHC reform with an aim for more people-centered, coordinated, and continuous PHC services that are accessible and affordable. Georgia has taken a whole system approach, starting from expanding the benefit package, adjusting the model of care to deliver these services, addressing health workforce challenges, aligning financial incentives, investing in digital solutions, and strengthening governance arrangements. Successful implementation of online consultation model for COVID patients by primary care providers stimulated investment in infrastructure and telemedicine technologies. World Bank, the European Commission, the World Health Organization provided needed financial and technical resources to improve rural primary healthcare infrastructure. So also making adequate investments in PHC building and modern technologies is important. Without securing adequate funding, PHC cannot fulfill its key functions. Specific feature of the Georgian healthcare system is that the vast majority of primary care providers are private. Most of private owners simultaneously operate specialized outpatient clinics and large hospitals. So this creates incentives to limit service provision at primary care level and refer patients to costly secondary services. The service delivery model is still disease-focused and reactive and lacks features of people-centeredness. Current payment mechanisms differ from rural and urban providers. For urban PHC, it's based on capitation model. The rate was set back in 2012 and has never been adjusted for inflation or other factors. Rural doctors get a lump sum per month for serving their respective communities. Salaries are not high enough to attract new physicians in rural communities. This limits possibilities of serving remote communities and villages. Of course, we do realize that there are a lot of challenges that needs to be addressed as soon as possible. Therefore, the ministry launched a new PHC reform. And with the implementation of the PHC reform, we work to mobilize additional budgetary allocations and better align financial incentives with desired and measurable outcomes. With the World Health Organization support, Ministry developed the roadmap for PHC development in 2020-2025, which enforces adoption of a priority service program under increased per capita payment by 30% of providers by the end of 2020. In addition to basic capitation, add-on payments will be introduced to improve chronic disease management as well as to improve early childhood programs. After 2023, once a new information technology module information system is introduced for primary care providers, we are trying to move towards results-based financing to encourage good performance. In summary, in order to meet the changing needs of the population, priority must be given to increasing accountability among providers, shifting to performance-based outcomes, separating specialist services from PHC packages, and building networks of multidisciplinary teams. Furthermore, provider networks should also be motivated among rural providers to ensure sustainability and quality of services. With this, I would like to thank everyone for preparing this excellent report, which is very helpful for guiding our future work. And I thank you, Cheryl, for this opportunity to be a panel member, and I thank all organizers for this. Thanks. Over.
Thank you so much, Dr. Gabunia. So many interesting insights from Georgia, and I really appreciate how you shared that this window of opportunity that came out in the report in terms of the political economy, that taking those windows of opportunity, and in the case of Georgia, really using the tragedy of COVID to turn it into an opportunity to revamp the primary healthcare system and a major shift to digital platforms and forms of delivery. So I think that's something we grappled with a lot, thinking about how to make sure that financing is flexible enough to adapt to those rapid changes. So thank you so much for highlighting that. Now I'd like to turn it to Professor Musa to share from his perspectives, multiple perspectives from provider and academia and others, and share your reflections on the findings and recommendations, please.
Thank you for having me. I'm not sure that you can hear me. I hope you can.
Yes, we can.
All right, great. I'm so sorry that I struggled to get in. Using the telephone to talk to you, but I'm very glad to be part of this panel. My name is Shabir Musa, and as Cheryl has indicated, I'm an actual doctor working in Soweto, Johannesburg. I did some work based on the work in Soweto for the National Treasury of South Africa, and currently I'm the executive coordinator of the Afro-PHC, which is the African Forum for Primary Health Care, trying to bring providers, that's the primary health care team members from across Africa together. And in fact, our engagements with the work done by Cheryl and the Spark in Africa have actually been quite key to developing the conversation amongst providers. Perhaps before we even talk about how Afro-PHC is thinking this through as providers on the ground in Africa, I think we share this idea that Captain puts in the article, the comment, that we need to get beyond rhetoric. And I think that as Gro Harlem talks about, it's often too easy for the UHC conversation to be captured by hospitals, and that primary health care gets lost in it. And in Africa, that is in fact a real problem. We support fully the idea of pool financing, and I think very much more public financing, but particularly the idea that we need to spend more on primary health care. But we fully support the idea that we need to spend better.
Professor Musa, I think we may have lost your audio. Give a moment and then see if we can reconnect. Professor Musa. So apologies, it seems that Professor Musa has dropped off, so maybe we'll switch to Dr. Garba to give the CSO perspective on this, and hopefully we'll be able to reconnect Professor Musa. Dr. Garba, over to you.
Thank you very much. I hope you can hear me also.
Yes, we can hear you.
Okay. So thank you very much for the opportunity to speak in this important global launch of the Commission for Financing for PHC. This is from Abuja, Nigeria, one of the, I must say, a focal country within the low and middle income countries. The report is talking to us directly in how we can improve in our primary healthcare financing. I'll be speaking on the harnessing civil society influence to strengthen government accountability for primary healthcare financing. Very important too, if we are going to see the gain of the growth and also addressing the primary healthcare financing. So let me begin by providing a quick summary from the findings of the report before I give you a practical example from Nigeria regarding the PHC financing. So the biggest question is why we need to harness society influence to strengthen government accountability for primary healthcare financing. Some of the reasons, most of them have already been mentioned in the report, but I'll just take some few. For example, the underperformance of the countries, especially in Nigeria, in Africa, and many other low and middle income countries. The funding for the primary health care is insufficient, including also from the government. Access to PHC services remain inequitable, high out-of-pocket payments in many countries, and also fragmentation of the financing for PHC. What I mean by fragmentation, it means that you could see a government funding for the PHC, development donor access, private sector initiatives, the civil society, but most of the financing are not properly coordinated. So we have a lot of fragmentation. The financing for PHC is also in many places dominated by relatively unregulated private expenditure, and also the capitation payment in many places also seems to be very low or not organized or not. These are some of the reasons why we are talking about the reasons to harness the civil society influence. And how do we harness that influence? If I jump into Nigerian example, in using the evidence to drive the advocacy and accountability. For example, the Lancet Commission report that we are hearing today. And also, we need to understand the framework for people-centered financing for PHC, the resource mobilization, the resource allocation, the pooling, utilization, and also evaluation. We also need to ensure that the effort on budget advocacy and accountability, like training and coaching, is also entrenched in our country and also creating opportunity for dialogue between the CSO and the government, within policy makers and the political actors. So coming back to Nigeria, before I give you an example of what accountability measures should be put in place by CSO, one of the examples in Nigeria is Basic Healthcare Provision Fund, which is one of the innovative financing to finance the primary healthcare in Nigeria. It is annually the government total revenue from Nigeria is allocated for the Basic Healthcare Provision Fund. We're talking about money a little bit over $200 million annually. And this funding is directly invested to support the primary healthcare financing through different gateway mechanisms. So about 45% of this money goes to the National Primary Healthcare Development Agency, which distributes the money to the state. And from that agency, the primary healthcare centers receive money on a quarterly basis. And this money is meant for improving human resources, drugs, and also addressing the issue of laboratory investigation. The other gateway for the Basic Healthcare Provision Fund goes through the National Health Insurance Scheme to all the 36 states in Nigeria, state health insurance scheme, and also goes directly to the primary healthcare centers. What is that money meant for is the taxation aspect of the healthcare financing for the CHC. Money is provided to support vulnerable groups in Nigeria. For example, women attending antenatal care, they still on the fight for immunization, nutrition, malaria, sickle cell disease, and so many. This is the gateway for that. Another 5% money goes to addressing outbreaks of diseases and also improving ambulance against accident and emergency, and also referral to the THC finance. This is in summary the Basic Healthcare Provision Fund. What are the measures, in the practical example that I'll provide in Nigeria that promote accountability for government for this funding? The CSOs in Nigeria, we have an excellent report and a case study of tracking the money from the national to the state to the primary healthcare center, the distribution and utilization. NGOs develop scorecards, policy brief, advocacy brief to support the government to track the money from the federal down to the primary healthcare center members through work development committees and facility health committees to also engage the leadership of the primary healthcare center to ensure resources. Another area that we are also doing in Nigeria is to put the CSOs and the government on the same table to design, to plan, and by ensuring that the ministerial oversight committee at the federal level and also at the state level, the civil society has a seat at and transparency. Of course, also regular advocacy and dialogue with the various agencies of government to ensure that the money is available and also that the dashboard, we know how much is coming out from the government, how much is going to all 36 states in Nigeria, and also how much is going to each of the primary health centers. These are some of the ways that we are doing in Nigeria to ensure that the accountability from the government is also enshrined in the Basic Healthcare Provision Fund. And at the end, the somewhat question that we need to also, okay, let me just, somewhat question for this accountability. Basic Healthcare Provision Fund, we are seeing more community participation through this process, and also at the same time, we are seeing greater engagement of civil society with the government to plan. The last thing I want to mention is that the biggest missing link in ensuring is by entrenching accountability and transparency. Thank you very much for the opportunity. Over to you.
Thank you so much, Dr. Garba, for those very specific examples of how civil society organizations can participate in the process of primary healthcare financing and help ensure accountability. And I heard the importance of having a platform, having these platforms to engage, as you said, a seat at the table, but then also having some transparency in the tracking and data and dashboards so that you can actually see that the funds from the very beginning, in this case, the Basic Healthcare Provision Fund, make it all the way to frontline providers, which, as we found, is one of the biggest challenges in PHC financing. I think Professor Musa is back, so I'll invite you to complete your remarks. Professor Musa, we're not hearing you yet. I'm sorry, we're not able to hear you, Professor Musa. I think we'll move to the Q&A and discussion part of the panel, and if you're able to connect your audio, we'll turn it back and allow you to complete your remarks. But in the meantime, I'd like to summarize some of the excellent questions and reflections that are in the Q&A box, and maybe just to kind of aggregate them a bit and pose them back to our panelists, but also to the Commission. There are some that are directly related to the report itself and the recommendations. So we have a number of questions around the issue of engaging private providers, how to engage them as partners in primary health care, some questions around how to engage communities, and then some questions around governance and those kinds of structures. So maybe we'll start with those big categories and ask our panelists to provide some more reflections on some of those challenges and what they've been able to do to manage them. Maybe if I could start, though, there was a question early on, and it's come up a couple of times in the chat, about a target for expenditure for primary health care. And does the Commission, did the Commission grapple with the idea of targets, how much should be spent on primary health care and what to do about that, and the balance between spending more and spending better? I don't know, Cara, if you'd like to jump in on that one.
Sure, thanks, Cheryl. Now that was a question that came up lots of times in our discussions, and I have to say we chose quite deliberately not to set a target. We felt that on first of all that just the measuring levels of expenditure with the adjustments that we made to the data in the Global Health Expenditure Database revealed such low levels of spending in so many settings that just increasing PHC expenditure would be a significant achievement. There's lots of targets out there, and I know things like the WHO team have put together some costings of PHC packages that I think could be usefully used to advocate for increased spending. But we just felt that that targets were not an especially powerful way of motivating countries to spend more on PHC. The other thing is that the level of the target will be very different depending on different circumstances, and that's both related to the size of the package that is being provided, but also the macro fiscal capacity of a country. And so to have one, obviously one target won't fit all, and even something that disaggregates targets by income level, we felt was not an area that we wanted to go into ourselves.
Thanks so much, Cara. Great. So maybe we'll turn to Dr. Gabunia and address the question about how to engage the private sector in the delivery of primary health care, and what does that mean for the financing tools and mechanisms that are most effective?
Thanks, Cheryl. That's a very important question, given the context in Georgia, where we have almost 80% of primary care providers private. Of course, to have primary care providers engaged with the service delivery, it's important to provide adequate level of financing or service reimbursement, because private providers, they not necessarily, but in a vast majority of cases, they are profit-oriented. And sometimes the high level of vertical integration and profit orientation may create some risks for service delivery and stimulate high referrals to secondary level services. So in Georgia, it happens that, as I mentioned, private providers, they operate primary care facilities as well as they operate hospitals. Therefore, it's very difficult to deal with the competing interests. However, we are trying to use different regulatory levers, including referral criteria, care pathways as well. However, it's very important to have a more strong gatekeeping mechanism in place to avoid unnecessary referrals. And at the same time, to have primary care providers adequately funded so they are still interested in doing this business for the government. This is, I think, the key challenge, and we are dealing with that right now. Thank you. Over.
Thanks so much, Dr. Gabunya. I think you actually answered a number of the questions that are in the chat, and that's really what's the whole kind of complement of mechanisms and tools that you need to both engage the private providers, make it worthwhile for them to engage, but also then direct behavior to kind of stop that natural tendency for over referrals and utilization at higher ends of the system. And I would say that probably also pertains to public providers as well, but just maybe a stronger pressure coming from private providers. I don't know if Professor Musa is back, but there are a number of questions in the chat related to provider incentives and how to construct the incentives in a way that will achieve these objectives of shifting more utilization to primary healthcare. And I don't know if you want to, if you're back, if you can share that experience with us from South Africa. Okay, I'm sorry, I don't think Professor Musa is back. That maybe I will turn to Ms. Kaushal to address some of these questions that I'm seeing come in about the public financial management system and how do you engage with the Ministry of Finance and make sure that the PFM system is moving in the same direction as the objectives for health financing and primary healthcare financing in particular. Ms. Kaushal, would you like to take that?
Cheryl, thanks for letting me in on that. The Ministry of Finance, we believe in ensuring that the person at the last mile gets the benefits, and that's why the Government of India's mission is Antyodaya. So here the PFMS system is a powerful tool, and we are able to even track how much there is delay in crediting the state share, the matching share, or put in an inbuilt check whether the Treasury, whatever funds we are being released for the National Health Mission or for other new flagship schemes, they actually flow from the Treasury. They don't sit there parked. So the government has launched financial reforms, and there are means of tracking the financial progress of these schemes. We also intend to move towards the just-in-time releases, and those, of course, we are working towards that, and that will really ensure that even the states, most of the subjects, unless the state is also pushing in as much resources, then the entire resource envelope increases. And that is a powerful way of increasing and ensuring what the Commission has highlighted, quantum as well as its flowing to the ultimate objective of strengthening primary healthcare, which is the bedrock. Thank you, Cheryl.
Thank you so much, Ms. Kaushal. I'd like to turn it now. There are a number of questions in the chat related to involving and engaging communities. And Dr. Garba, I'd like to turn it to you to give some more reflections about how to better engage communities in all aspects of primary healthcare financing. We looked at the accountability in your initial remarks, but all the way through even provider payment, if we're talking about capitation and population-based payment, that of course involves communities. Do you have any reflections for the audience on how to better engage communities at all steps along the way?
Thank you very much for this question. So in the practical way of engaging a better engagement of the community for the primary healthcare financing, when I go back to the way initially about the basic healthcare provision fund. So in engaging with the community, anywhere we are, we need to engage the community from the planning, from the design, from the annual budget processes. Like an annual budget process, the community needs to be engaged right from that. The parliamentarians, the political actors, we must engage the community as the priority that needs to be captured in the budget. They need to know about the process. They need to participate through the public hearing and some fora within the policy makers at the local government and at the state level. They also need to make contributions. Where are we going to site our primary healthcare services? What are the which services will give them better satisfaction? So in summary, the point I'm trying to make is the community needs to be engaged not at the end, but right from the planning and the design. And also when the money is available and disbursed from the federal government in Nigeria to the state and also the local government, we need to inform the community the amount of money that has been disbursed to the facility nearby. So for example, if, for example, $50,000 have been disbursed to a particular primary healthcare center, the community members need to be informed that social amount of money is available so that they will be able to track the money, can walk into the facility and demand for information and also demand for quality of care. So these are some of the ways that we need to actually inform and engage the community meaningfully to support primary healthcare financing. Thank you and over.
Thank you very much, Dr. Garba. And maybe to continue on this theme and connecting it back to governance, I'd like to turn it over to one of the commissioners, Dina Balabanova, to discuss a bit more the thinking around that linkage between communities all the way up to governance.
Thank you very much, Sheryl. This is a very important question, and in our commission we brought examples of countries where technical solutions have leveraged social movements, drive to enhance equity. So what we try to illustrate in this commission, and I hope you can look at the examples, that it is difficult to implement technical solutions in the absence of economic, political, and social processes in the society. So all these decisions around spending more, spending for the particular groups, for example, the poorest, for women, as somebody made a comment, how do we spend for these groups that are very often not at the forefront of society's priority. So this is a political decision. What we would like to emphasize is you can't just design a technical solution and say you're going to involve community. It's about a shift in power, and this very often is part of the social contract in a country. It is not something that you could do quickly without foresight and anticipation of this. Thank you.
Thank you so much, Dina. I'd like to try one more time to see if we can connect Professor Musa. I'm still not hearing. I'm wondering then maybe, yes?
I was going to say maybe as Professor Musa is having a problem joining, what I could do is just point participants in the webinar to his commentary that's on the Lancet Hub site that actually speaks really eloquently about providers' roles in this landscape. And one of the things he talks about is actually provider payment and capitation, and a really interesting experiment they had in South Africa informing the design of the new national health insurance system. And it actually relates also to Dr. Gabunya's comments about how to engage the private sector, because this issue about the level of capitation payment is really important. So that capitation payment needs to be set in a realistic level in relation to the expectations of the package of services that providers are responsible for. And if they, because if the capitation is too low, they'll either not engage at all, or, as I think we know a little bit from the situation in Georgia and in other countries as well, if the capitation payment hasn't been adjusted for many years, what happens is that providers will find ways of shifting the burden of that shortfall back to patients, either in the form of informal fees or in the form of balanced billing. So those providers are really important actors in this system. They need to be brought on early, as Tim pointed out in the presentation of the results. There will be winners and losers in terms of providers, but also involving them early in the design of the system and making sure that the capitation rates are set up at a level that they'll want to participate in a way that protects patients is terribly important.
Thank you, Kara. We are fortunate that we have the commentary by Professor Musa to see his reflections there as well. I think at this point, I'd like to just summarize what I've heard from this really stimulating panel and then hand it back to Kara to close us for today. But I think just getting back to the whole focus of this commission, and that's putting people at the center of primary healthcare and then organizing financing also with people at the center to support that direction. And so a lot of discussion today about service delivery and how important it is to look at how service delivery can be organized to meet the needs of people, very much focused on the communities and their needs, but also involving the private sector in many countries. That's the reality. And there are ways that private providers can be brought in to serve the public interest and objectives here. But we need to stay dynamic. And we saw during COVID that the changes in service delivery were very, very quick. And the introduction of technology and the change in the platforms of service delivery. So financing needs to also be flexible and dynamic. We heard a lot about resource allocation tools, very effective tools to get resources to allocate it to primary healthcare, but then protect it along the way, all the way down to frontline providers. How to create the incentives for those providers to deliver high quality care efficiently. But we need to be very proactive. Incentives alone aren't going to take care of that. There are other complementary measures, referral guidelines, other measures to keep the incentives right and to keep the people at the center of service delivery. Finally, quite a bit about governance and community engagement and how to make sure that communities or civil society organizations are at the table from the very beginning, and then have tools and transparent information to be able to play their role of accountability in the system, and that the governance arrangements have to acknowledge the difference and the shifts in power that will be necessary to really put primary healthcare at the center of the health system and people at the center of primary healthcare services and financing. And then all of these changes, of course, are difficult and are often very incremental, but to be ready when there are windows of opportunity and even turning difficult moments into windows of opportunity to make these changes and to carry this agenda forward. So a huge thank you to all of the panelists and the presenters and other contributors, and of course, all of the great questions from all of you in the audience. It was a wonderful discussion, and I hand it back to you, Kara.
Thank you so much, Cheryl. Thanks for handling that set of questions really nicely and engaging all of our presenters. I just want to make two last points in closing this session. The one is about the Commission's afterlife. So this is really, although it's the end of one phase of our work in terms of publishing the report, we're extremely keen that it's merely the start of a process of dissemination and policy dialogue about how to finance PHC better. And we're really looking forward to talking to national decision makers and technical advisors in the coming months through a series of further events that will be taking place to support the communication of the Commission. We're also very interested in doing more work to kind of adapt and adjust the report's findings to specific country circumstances. So if you have suggestions or ideas about how that can be done, we'd really like to hear from you. We're also working towards a new research agenda that will follow on from some of the findings of the report. And I think there was a comment in the Q&A actually about sort of aligning these recommendations around measurement, global standards, and yet having countries set their own definition of PHC expenditure so they can so that they can monitor and track that over time. And there is a contradiction between those things, right? There's so many compromises that are needed in order to have a single comparable measure at the global level, and yet have it be useful at the country level. So we're very interested in engaging with technical agencies on how best to monitor PHC spending and how to improve how PH spending can be made more effective, and really bringing people to the center of these arrangements, as Cheryl mentioned. I would also draw your attention to the resource hub on the Lancet website and the supplementary materials that have been here available on the webinar. The executive summary of the report is now available in English and Spanish and Portuguese, and in French and in Mandarin. So those will all be available on the Lancet web. And I'd really encourage you to engage with those and to circulate them. I'll close then with thank you. So I'd like to first thank all of the panelists and speakers in today's launch event, and really to thank again the commissioners who worked so hard over the last 2 years to create this report. I'd like to thank so many others who contributed in many ways: the research team, the case study authors, our research assistants, our own management and communications team for the Commission, and to the many friends of the Commission who were willing to jump onto a Zoom call at various points to debate issues and help to advise us on the right framings for this work. I'd like to thank the Bill and Melinda Gates Foundation, who funded the work, to the Lancet Global Health team for their support in producing this event today, and to all of you for contributing and participating. So thank you very much, and enjoy the rest of your day.